Hello, my name is Jim Meadows. Welcome to volume 1 of the series Manual Therapy. This volume concerns the scan examination and differential diagnosis. The scan examination is probably the most important of the examinations that the therapist will carry out. It protects the patient's health by its potential for demonstrating serious pathology. Once mastered, it takes only a few minutes to complete, and when its returns are considered, is extremely cost-effective. Designed by Dr. James Cyriax originally for physicians, it is intended to generate a medical diagnosis. However, many patients attending for physical therapy arrive without benefit of this examination for one reason or another. This examination must be carried out either by the physician or the therapist before any treatment is undertaken. It is important to understand that no single test result will afford a diagnosis. It is an integration of all of the results, both positive and negative, that will lead to the appropriate treatment or management program. The term scanning examination is unfortunate in that it implies a superficial investigation. In fact, this examination is perhaps the most comprehensive, non-biomechanical clinical examination available for the musculoskeletal system. It, or one very much like it, must be carried out routinely, especially now that in many states and provinces the therapist has primary contact privileges and is often solely responsible for the well-being of the patient. In essence, the scan examination is a combination of selective tissue tension testing and screening tests. Selective tissue tension testing is essentially the isolation of the action of a specific tissue, at least as much as is possible, and making the tissue perform that action in that isolation, and then assessing its ability to carry out its function and the degree of symptoms produced during the test. An idea of the state of the tissue is gained when this is assessed. In regards to this examination, the musculoskeletal system is divided into contractile, inert and neurological tissues. Contractile tissue includes muscle, tendon and the tenoperiosteal junction. Inert tissues are the joint capsule, ligament, articular surfaces, synovium and meninges. Neurological tissues are of course the brain, spinal cord, nerve roots, spinal nerves, nerve trunks and peripheral nerves. Certain tissues, because they are easily affected by both passive and resisted tests, may be considered as falling into either group. These include the bursae and bone. To test the contractile tissue, the muscle is made to contract isometrically, thereby reducing the contraction's effect on the joint tissues and so minimizing the risk of a false positive. Inert tissue is evaluated by passive movements, ligament stress and dural tests. Neurological deficit is determined by key muscle resisted tests, sensation testing, deep tendon reflexing, clonus tests and other adjunct tests. The second part of the scan are the peripheral screening tests. These are quick, non-comprehensive and non-specific tests that indicate if a particular joint or region requires a proper examination. These must not be used to generate a definitive diagnosis and can only include, not exclude, a joint as being dysfunctional. Commonly used screening tests include squatting, Faber's and grasping the hands behind the shoulders. This video would demonstrate a series of tests that are more comprehensive yet still quite fast. Of course, while the objective examination is important, the subjective cannot be ignored. In the history, the patient profile, site, severity, nature, irritability and constancy of symptoms must be sought, as must the mechanism of injury, if any, onset and offset and behaviour of symptoms, exacerbating factors, previous episodes and treatment, medical history, medications and the results of objective investigations must all be queried. Observation of the patient will also generate information such as obvious deformities, as scoliosis, lateral shifts, torticollis, scars, atrophy, etc. should be noted. A determination of habitual posture cannot be made until the patient regains his or her habitual state, as the current posture may be the result of the problem rather than its cause. As already stated, the purpose of the scan examination is to generate a working diagnosis. Such diagnosis will include conditions such as supraspinatus tendinitis, fourth lumbar disc prolapse with fourth motor root palsy, acute traumatic arthritis, systemic arthritis, fracture, grade 2 ligament tearing, etc. It must be understood that these diagnoses will be provisional until more objective testing can definitively establish them. However, in most cases, the cost and effort required is unnecessary and treatment can be initiated immediately. It is only when serious pathology is suspected or if treatment is failing that the patient requires further tests. When considering the results of objective testing, remember that X-ray findings are often incidental and MRI results are notorious for generating false negatives and positives. In all cases, the objective results should be evaluated after the clinical examination to avoid colouring that examination. The diagnosis is not arrived at by collecting all of the data and then assessing it. Rather, it is a continuous process that results in the formulation of differential diagnoses that are discarded or retained as more information becomes available. At the end of the examination, the therapist is left with one or more diagnoses that have various degrees of probability. Very often, in fact more often than not, no reasonable diagnosis can be arrived at. In these cases, the examination is considered to be negative, and further testing is required to produce a biomechanical diagnosis. When positive, the type of treatments that would be administered would include referral to a physician, rest, exercises, traction, friction massage, anti-inflammatory modalities, etc. During Tape A, the scan examination of the lower quadrant will be demonstrated. Each part of the examination will be broken down into its component tissue type in order to explain the principles of the examination. The components will then be put back together and the examination carried out as it usually is in the clinical setting. The cervical and thoracic scans will be carried out in the straightforward clinical manner and the viewer will be expected to extrapolate the principles from the lumbar tape. The peripheral passive movement and stress tests have been demonstrated on volumes 3 and 4 and are therefore not included in this tape. Thank you.